Good evening, everyone. Thank you very much for joining us for this talk on how to help your child sleep well. My name is Nicola Harvey and I work with Prevention Partnership and Family Support in Tusla and Donegal. I am one of a group of people from different services across the county who are known as Parent Support Champions. The Parent Support Champion project is about supporting parents by providing them with evidence-based information, and we do this through promoting key messages for parents through initiatives like these talks. For more information on parenting, you can go to Parenting 24/7 or mychild.ie. The Parent Support Champions have been running these talks for a number of years now, and the interest in the talks is ever increasing. The talks are recorded thanks to funding received through the Parent Support Initiative under the HSE Community Healthcare Area 1 and the Children and Young People Services Committee. As a result of this, our reach is widening now to include parents across Cavan, Leitrim, Sligo and Monaghan, as well as Donegal. There will be a question and answer section at the end of the talk based on some questions put forward by parents. We are delighted to have Denise Gillespie as our speaker. Denise is an advanced nurse practitioner in the HSE with many years' experience supporting parents of babies and children in the early years around behavioural issues. Denise has a particular interest in the area of sleep and has contributed to the mychild.ie website, as well as educating her colleagues throughout the country on this topic. Without further ado, I'll pass you over to Denise.
You're all very welcome to this talk today on helping your child to sleep well. What I want to do is just basically go through the basics, the understanding, what happens during sleep. And then I'm going to go into a few of the common sleep problems that I would see in my everyday practice that parents would identify and give some tips on how you can support your child to sleep well. So just to start with, it'd be great if we had a magic button, for sleep, but unfortunately that's not the way it goes. And what I hope you have at the end of this session is some practical ideas of way that you can support your child to learn to sleep well. And when I say support your child to learn to sleep well, that's actually very important because sleep doesn't just happen, it's a learned behavior. And the tips that I'm going to be giving you today are really around what you can do as a parent to support your child to sleep well. So, just to start off with, why are we focusing on sleep? As somebody who works with child behaviour, I was very interested when I started off and the post I'm in now. I was previously a PHN, and I was seeing children referred with behaviour difficulties, but you can't look at behaviour in isolation. And if a child's not sleeping well, it's reflected in behaviour, and that's where my interest in sleep came from. But sleep's very scientific, it's really well researched, and there's an awful lot of very useful information has been found within the sleep scientific community, and I'm going to share some of that with you today. So sleep's necessary for all children to function well, and sleep deprivation can cause problems with attention as well as behaviour. It impacts on every aspect of growth and development, and if you have a child in the family with a sleep problem, then usually it affects the whole family. Just to mention about perception, every family is different. And when you first bring home a new baby from the hospital, it seems like you feel like you'll never sleep again because of the frequency of the wakenings, that there's short breaks between when the child sleeps and wakes up. But most newborns actually sleep somewhere between 14 and 18 hours in the 24, although as a parent, and I have 4 children myself, it never felt like that. So perception is important because what's a problem for one parent isn't a problem for another. And in relation to sleep, there's no black and white, there's just a lot of grey, and it's just working with what suits your family. So we're just going to look a wee bit about normal sleep. So as I said before, sleep's essential for everybody. It's actually a very biologically complicated state, very well researched, but quite complicated. But importantly for us and what we're covering today, it's a learned behaviour. So there's a lot you can do to support your child to have good sleep habits. And there are 2 types of sleep. There's rapid eye movement sleep, also known as REM, and there's non-rapid eye movement sleep, which is also known as deep sleep. So this slide here is probably one of the most important that I'm going to show you in this session. And when you see this slide, the wakenings of children really make sense. So if you look there, this slide starts at 8 o'clock. And if you look at the deep non-REM across the bottom there, you can see that there's a lot of deep sleep in the first 3 to 4 hours of the child going to sleep. And most parents will report that the child, when they go to sleep, they sleep soundly for 3 to 4 hours, and then the wakenings start. Each one of those spikes is a sleep cycle. And as part of a sleep cycle, there's some deep sleep, some light sleep, and then wakening up. So all those purple boxes are when the child wakens. When a child wakens, transitioning from one sleep cycle to the other, they open their eyes and look around. If everything is exactly the same as when they went to sleep, then they will fall back to sleep. And even as parents yourself, you can think that when you wake up during the night, sometimes you'll remember you saw the time in the clock, sometimes you won't. But for a child who has particular sleep associations that we're going to talk a good bit about later, if something is missing at these transitions that was present when they initially went to sleep, then their brain looks to recreate it in order to fall back to sleep again. And that's where we see the pattern of frequent wakenings happening. And then for those of you that are struggling with children who are wakening frequently during the night, usually if you look there at 5 a.m. towards morning, there's another period of about an hour of deep sleep. And for the parents I see, that's the hour that's keeping them going during the day, that they get about an hour and then they're up for the day. So just to talk a wee bit about developmental milestones in relation to sleep, you know, in the first 6 months of life, really, there are two very important milestones in relation to sleep. The first one is called sleep consolidation, commonly referred to as sleeping through. And that's the child's ability to be able to sleep for a longer period at night time. And the researchers would say somewhere between 12 and 5, they have a longer period of sleep. But there's also the development from about 3 months of sleep regulation. And that's the infant's ability to be able to self-soothe. That's what it's commonly referred to. Basically, what that means is they can do those transitions between sleep cycles without needing the parent to intervene. And that's very important, you know, because then it's perceived that the child sleeps all night. So when we're talking about sleeping all night and you know the day, we look at the day in 24 hours and how much sleep does a child need. And really, the very simple answer is the amount of a child needs to feel well rested. That can vary. You know, there's quite a range of norm, and I'm going to show you a slide to show that in a few minutes. Parents can recognise the behaviours associated with being overtired. It can be whingy or moodiness, but a lot of parents aren't aware that if you have a chronically sleep-deprived child, they present as being hyperactive. So they're really, really busy, which you would think if they're tired, if we are tired as adults, you know, we're a bit lethargic, whereas the children go the opposite way. So if you've got a hyperactive child, that can be a manifestation of sleep deprivation. This is a very interesting slide here. This is the one I was saying about how much sleep does a child need. If you look at that, the dark blue there in the middle is the average, you know, what most children will get, you know, what's recommended. And then the light blue on either side is your range, you know, if you think of it as a bell curve like you see on graphs. So for an infant of 4 to 11 months, you know, the average sleep, including naps, is 12 to 15 hours. But you could get a child that is managing on 11 hours, including naps. And then you'll always get the child that has like maybe 16 hours, including naps. So the dark blue is really, you know, what's recommended. And most children would fall into that, but you always get the outliers on both sides. And in this slide here, the most sleep-deprived group are teenagers, because they think all the research is pointing towards electronic use as contributing to them not getting enough sleep. So just to say that there was a very big study done back in 2017 looking at sleep in Irish children. We had done a small study between Kildare and Donegal, and we only sampled 150, but Sinead Hanavan sampled 30,000 children and parents from the Grown Up in Ireland study. And why I'm showing you this slide is A lot of the time when you go looking for information on sleep, you might go into UK websites and their stats are quite different from us. In Ireland, most children go to bed slightly later, probably because the parents are working later, and they actually get up a wee bit later. You'll know from the TV and stuff that kids in the UK are often up at 6 o'clock. So 67 to 78% of all children in Ireland go to sleep between 7 and 9, and 48% waking between 7 and 8 in the morning, with only 13.5% waking between 6 and 7. So it's just to give you an idea that if you're reading some stuff, you kind of need to know which country the information is coming from, because they might give you unrealistic expectations compared to the Irish system. Now, Sinead's research was very interesting in that she asked mothers if sleep was a problem for them. And 30% of parents said that at 9 months, sleep was a problem for them. But 22% said it was still a problem at 3 years. And interestingly enough, 12% at 5 years. So that's why we've kind of moved towards, trying to deal with the sleep problems earlier, because they don't just outgrow them. They sometimes need a bit of help to learn how to sleep well. When I talked earlier about the children who could self-soothe, these children are often referred to as signalers versus non-signalers. So a signaler is a child who wakens during the night, can't get back to sleep by themselves, and they need the parent to help them to get back to sleep. The non-signalers are the children that can shuffle about a wee bit. They're awake as well, but they don't need the parent to help them to get back to sleep. And it's estimated across all children, all the research that's done across the world, 20 to 30% of children are signalers at 12 months. So you've got about 1 in 3 children still need help from the parents to get back to sleep. And usually, just to mention that when I get the parents to keep sleep diaries for me, and we're counting up how many hours sleep the child gets, on average, the parent could be getting half of that, because, they might not go straight back to sleep when the baby goes back to sleep, or they're up earlier or going to bed later. So parents are often more sleep deprived than their children. So when we're talking about sleep, we talk about the 4 pillars of good sleep. So I'm going to talk a wee bit about sleep hygiene. That's the environment that you sleep in. It's not about cleaning sleep. It's a funny term, but it's the environment that is conducive to sleep. We talk about a regular sleep schedule. That's the going to sleep and getting up at roughly the same time. A regular bedtime routine done in roughly the same way at roughly the same time each evening are very good for introducing cues for sleep. It's all signals to the child that, and now we go to bed. And then consistent daytime behaviours and habits. Probably the most important one of them is a consistent morning waking time, and also regular meal times all contribute to the circadian rhythm, the body's 24-hour clock, and the progression towards sleep at night time. So sleep hygiene. Really, the single most important thing in relation to sleep hygiene is that you have a dark bedroom. Now, the sleepy hormone melatonin is produced by the body in darkness. It's made from the pineal gland. So if you did nothing else, if you took nothing else away from this today, you could buy a piece of blackout lining, get Velcro and put it straight on the surround of the window. And by making the room dark, you're promoting the production of melatonin. That's the biggest thing that's important. Obviously, the temperature in a room, and we all know this from the Safe Sleep campaign, in and around 18 degrees at night time. And you're going to hear me say quite a lot, there should not be any screens in the bedroom. There's an awful lot of research coming out on screen use, especially since COVID, and screens should not be in the bedroom. So a regular sleep schedule, it's about, keeping the rhythm of the body consistent. So really what you're looking at is that morning wakening should be around the same time each day, within about half an hour. Obviously at the weekends, and this can be a problem actually for older children who you've heard of jet lag. They talk about sleep lag in teenagers. You cannot make up for sleep loss during the week at the weekend. So all it does is throw the circadian rhythm out of sync. So it should be within about half an hour of the morning wakening time during the week at the weekends. Naps are very important, and we would never hold back on naps to try and help a child sleep well. In actual fact, if a child misses a nap, they're probably more likely to waken up during the night. Regular exercise for toddlers is essential for sleep, but make sure it happens during the day and not just an hour before bed. And also regular mealtime support the body's own biological clock. So just an idea on some activities, pre-bed activities, for the wind down in the hour before bed. You want the screens off for at least for an hour before bed. So turn the TV or the tablets and things off. You would start with supper. Why we start with supper is that it can help in the production of the sleepy hormone melatonin through producing tryptophan. So carbohydrate and dairy. So, if they have cereal, they have some toast and some milk. This is a good way to support the production of melatonin in the evening. Things like colouring or jigsaws can be relaxing before bed, and also things like construction activities, they're relaxing. A sensory storybook can help relax, the ones that the child can feel the pages and it's got the different textures on it. Massage can help, but it needs to be used with caution and not be used just before they go to sleep. Because if a child's getting their feet rubbed or just before sleep, what can happen then is that it becomes a sleep association. And on the previous slide, I showed you where we have 67 sleep cycles during the night. Then at every sleep cycle transition, the child's looking to set that sensation of their feet being rubbed in order to get back to sleep. And then the other thing is setting limits on activities is crucial before bed. Some children will negotiate to keep the activity going and use them first and then, or when and then. So first we'll do this and then we're doing that. And actually the setting the rules and the boundaries around the bedtime routine is very important. And for some of the children that we're working with special needs, a visual schedule is actually very helpful for this. So the bedtime routine is really the anchor of the pre-sleep techniques, and when you repeat the activity, it reinforces it. So it's not particularly that you have to do anything in a set order, but it's just that A follows B follows C, and now it's time to go to sleep. And that's where when we use visual schedules, we could have a picture of the supper, then we might have a picture of teeth brushing, the storybook, and then bed. There could just be 4 pictures there on Velcro that the child can take off as they do each activity. And then they know when they've got them taken off, oh, now it's time to go to sleep. So also the cues for sleep help regulate the body clock because you're doing the thing in the same way each day. And really, you're starting to make a difference between day and night from about 3 months. So most babies under 3 months, they're in the living area with the parents and they take them up to bed at bedtime with them. But really what you're looking at is the lighting in the living room is probably going to be a bit brighter than the one in the bedroom. It's darker in the bedroom. So those are the subtle cues that there's a difference between day and night. Bedtime routine should only last about 30 to 45 minutes. And I know from talking to parents that come to the clinic that often it can take up to 2 hours with some parents, so don't start it too early. Because if you remember the previous slide that I showed you about the first 3 to 4 hours being mainly deep sleep, there's actually a period there before they're ready to go to sleep that the sleep gurus call the forbidden zone. And what happens in the forbidden zone is that the brain will not let the child go to sleep. Many parents who would come that I would see would call this giddy hour, where they almost get like a second wind and they're running around. If you try to put a child to bed in their forbidden zone, their brain's not going to let them go to sleep. So what you're going to see is a lot of resistance. And sometimes that's why, the bedtime routine can be lasting 2 hours. It started too early. Ideally, the routine should start around the same time each night. You can have a relaxing activity like a bath or a story as long as the child winds down after it. I've certainly come across some children over the years where actually having a bath stimulates them, so nobody knows your child like yourself. Repeating the routine reinforces the activity. So the more you do it, the more the child gets to know what to expect, the easier it gets. And you put your child to bed when they're drowsy. but not asleep. So don't let them fall asleep into the sound deep sleep on your arms, because if they fall asleep in your arms, then when they do that first transition, they're going to think, where did my parent go? You know, so you want them to fall asleep where they're going to be for the night in the cot. So just to mention a wee bit about supporting children with special needs, there are different things that can help children with ASD, autism, feel secure. And the visual schedule, like I would do sleep clinics and CDNT, and the visual schedules are good. And also the grow clock. And a grow clock is a clock that has red and blue. So when it's time to go to sleep, the clock lights up blue. And when it's time to get up, it goes yellow. And this is a very good visual cue for a child, even for the non-verbal children, that they know when it's time to go to sleep and when it's time to get up. And the timing of the lights coming off and on is set by the parent. So you work it around your own schedule. Social stories can help if there's a particular trigger for anxiety. You know, like if you're in the dark, you can use social stories to reassure them around that. And sometimes, you know, if you've got a stressed child, it can help if only one person puts them to bed. But really, it's very important from an early age that it's not the same person every night if there's two parents there, because that can lead to problems if that parent has to go out and the child won't go to bed, you know, with the other parent there. And sometimes children respond to hugs at bedtime. But other children, you know, might have weighted blankets and things like that. But that's really in consultation with the occupational therapist on your CDNT team. And again, those hand-eye coordination activities can help relax children with special needs before they go to bed. So what you want to do really is avoid creating a bedtime routine that requires the parent to be present when the child is falling asleep, or props which could become inappropriate sleep associations. The common props I would see are those toys that play music or light up and turn themselves off, or sometimes it's those projectors on the ceiling, or a bright light or flashy lights. All those things, you don't want them in the room. You want the room to be dark, settled, you know, calm, and you don't want anything there as the child falls asleep that's not there when they do the first transition after 3 or 4 hours. You try not to confuse the child by bringing them back to the living area once the bedtime routine is complete. Now, where this can be a problem is if the child has been put to bed too early in their forbidden zone and their brain's not going to let them go to sleep, then you'll get a lot of resistance. And sometimes parents just say, oh, I just took them back to the living area because, you know, they were just playing up. So really, you're looking at the starting place for that is look and see what time they actually fall asleep, and then make bedtime only about 20 minutes before that, and you should see that resistance to going to bed disappear. Try not to soothe the baby to sleep with a feed after weaning is established. So when you get to like 9-10 months, the need for the nutritional need for nighttime feeds has disappeared. Obviously, children, especially breastfed children, feed for comfort and things as well. But really what you're trying to do is don't feed them within the half hour of going to bed, you know, so have your routine with supper, give them their milk, and then do other things like brushing their teeth in the story. Rather, don't make the feeding the last thing to do before they go to sleep. Don't send the child to bed as a punishment, and the bedroom should always be a calm and happy place. So try to avoid that. And if possible, after 9 months, try and avoid having naps after 3:30. That's a tricky one. And that a lot of parents are collecting kids from creches and things, and the child, if they get 20 minutes on the way home, then there's difficulty getting them to bed at night time. So really what you're looking at is having a plan in place, you know, where you could have things to do in the car, you know, those things with pockets in the back of the seat that there could be toys in them, just to try and keep them going until you get them home. Be very careful about giving children caffeine containing food or drink in the evening. Now, most people would think, oh, sure, my kid doesn't get caffeine, but you have to look for the hidden caffeine. And like diet drinks have quite a lot of caffeine in them. Chocolate has caffeine in it. So you just have to be aware of hidden caffeine, and could this be impacting on your child's ability to get to sleep. And try not to encourage the child to do any stimulating activity or exercise in the hour before bed. So avoid the trampoline in the hour before bed. So establishing good sleep practices is just a matter of repeating the same things over again. So you're putting the baby into their bed drowsy but not asleep. Establishing a regular bedtime routine that we've discussed about. Set limits at bedtime and during night waking. And so if you say there's going to be 2 stories, you know, you don't negotiate 3, 4, 5 stories once you get into the bed. A regular schedule for meals helps the body's own circadian 24-hour clock rhythm, and making sure the child has plenty of exercise during the day helps for nighttime as well. So we're talking about sleep cues, you know, what to look for in small babies that can indicate that they're tired. And the baby could be staring into the distance. They're just staring. Or there could be like jerky movements. They could be yawning or fussing or sucking their fingers. Or, you know, they could have been playing quite happily and then all of a sudden they lose interest in people or toys. And there's a very good video that actually demonstrates the sleep cues on this website. The raisinchildren.net.au actually shows you the physical signs on a 4-minute video if you're interested. It's worth looking at because it demonstrates it very well. Daytime naps, from about 3 months really, baby's day and night starts to become a bit distinguished. So what you usually would see is maybe they're awake and there's a bit of fussing before the last feed. They have that last feed and then they might go maybe 4 to 5 hours, and that's when you see it sort of starting to stretch at night time. Children will usually continue to nap until they're 3 years old, and really the golden rule that we kind of would say is try and avoid naps after 3:30 if possible, because it can lead to a delay in falling asleep at night time if they have a late nap in the evening. So nap time should be at roughly the same time each day. And you usually find children are ready to go back to sleep 2 to 3 hours after awakening. And have a nap routine like the bedtime routine, but shorter. You know, quite a lot of toddlers will nap after lunch. But if you can get them into the cot for naps, but it's not necessary that they go into the cot. But what you're trying to avoid is the naps happening at the same time every day, say whenever you're taking them for a walk. While it's nice for you to get out, if they can't learn to nap and fall asleep, you know, without the movement of the pram, that can become a problem later on. You're also trying to avoid negative associations with naps like rocking or taking them in the car, and that can't be avoided if you've got multiple pickups, I know that. But what you're trying to do as much as possible is time the naps around in between the pickups. And you're kind of setting clear nap rules, especially with toddlers. Naps are a big thing, you know, and what I would say about naps is when they start to transition out of naps, when they drop their nap, you know, and that can often happen around between 2 and 3, you will get a period of quite the tired child. Sometimes it impacts on nighttime, you know, they're falling asleep too early in the evening, then they're waking up too early in the morning, and you just kind of have to go with it and work with it. It will resolve. It's just the body adjusting to the less sleep. But once the naps are gone, you usually find they sleep longer at nighttime. Just as I mentioned before, you know, breastfeeding, it's common for breastfeeding babies not to sleep through the night for a long period of time. And then some of them do start to sleep after a while, but then the things that can impact on whether they sleep or not, there's so many variables. You know, it can be down to the mother having a larger storage capacity for breast milk, or sometimes the baby just likes the comfort, the security, the warmth, the closeness and familiarity, you know, and that's fine. It's only, I would find sometimes it's when parents, maybe when maternity leaves come to an end and the child's closer to a year, that frequent feeding during the night when they're breastfed, sometimes it's difficult for the mother because she has to function at work the next day. So then we're looking at working to try and change the timing of the feed so as mum gets a few hours continuous sleep as well. So recognizing baby cues for sleep is good because it can, if you pick up when the baby's tired, they're not always hungry. Sometimes it's just that they are tired. So that, you know, the jerky movements, the staring into the distance, the losing interest. Sometimes if you just get them down at that stage, then that it's tiredness. It's not actually that they are hungry. And if the amount of time the baby toddler sleeps and feeds at night isn't a problem for the mother and her partner, there's no need to change it. There's absolutely no need to change it. And that's one of the biggest things in all things to do with sleep is it's only a problem if the parent says it's a problem. Just to mention, as I did before, electronic media and sleep. Screens emit the blue light, and the blue light interferes with the production of the sleepy hormone melatonin. So if children are on tablets and phones, then it's interfering with their melatonin production, and that can cause a delay in actually getting to sleep. Now, small children are more susceptible to the blue light because they've got a bigger lens in their eye, and that lets more light in than the adults, and that increases the time it takes the child to fall asleep. So just avoid the screens in the evening. And then they talk about sleep stealers, the electronic sandman. So TV in the bedroom can lead to sleep problems because it stimulates the brain. It can cut down on family time, and TV can affect dreams. So all the electronic stuff in the bedroom, really avoid it. Have good family rules around that. The other thing to be careful with is caffeine. And it's added to many drinks and snacks. So check before you give your child the drinks and the snacks. And then the other one that's become increasingly common, especially now that things have opened up again after COVID, is too many activities in the evening and not enough time to do them all. So like there's some kids, maybe 3 and 4 year olds coming through the clinic that are constantly in the car going with older siblings, because all the trainings are on and the activities are on in the evening. So it's just about, having a balance. It's all about balance and building in family time and relaxing time at home and not being in the car all the time. So the research is coming out now, post-COVID, on media use. And really it's saying it's quite complicated. There's a variety of factors that are influencing how media is affecting sleep. The time and what time of the day is the child using the screens. This would be more, not so much the small children, but definitely it's actually starting from national school now, where they're getting screens and they're on tablets. And, I think it's 40% of 4 and under have tablets. It's a very high percentage. So it's, when they're using the screens, so try not to use the screens for wind down in the evening. The location of where they use the screen, the research has shown if the screens are in the bedroom, there's definitely an increase in the time it takes for the child to go to sleep. And then also the content of the screen use, stimulation. 90% of studies show adverse outcomes in relation to screen time and one sleep outcome. And the outcomes they looked at were that the child slept for a shorter duration or they were later going to sleep. That's what the latest research is kind of showing in relation to media use. And then just to kind of mention some of the common sleep difficulties. So you've got sleep onset disorders, you've got difficulties setting limits or bedtime battles, they're often called, and a lot of them are around the child going to bed too early because they're in the forbidden zone. You can have what's called a sleep rhythm disturbance, where sometimes the child can get to sleep okay, but they have difficulty staying asleep, or they go to sleep too late and get up too late, or go to sleep too early and get up too early. We've got a group of things called parasomnias. The most common one of these would be night terrors and sleepwalking, and I'll mention a bit about them going forward. There's also a very common thing that's not widely known really among the doctors. If you go to the GP, they're not as aware of it, and it's called restless leg syndrome, and that's caused by poor iron content in the diet. And then you've got something called obstructive sleep apnea, and the most common cause for that is enlarged tonsils. So just to mention about restless leg disorder, what it feels like for the child, and I suppose because I go to the sleep conferences, there's always a lot of presentations around this. And I'm very aware when I'm talking to parents that when I ask them, there's a lot of children that are very fussy eaters, and maybe they'll have pasta, but they don't have the bolognese sauce. They'll eat potatoes, but they won't have the meat. And really, for the iron content in the diet, you need meat and green vegetables. So the small children that I would see, because I deal with preschoolers, they can't really describe what it's like. So you're looking at how they present. But I've talked to some older children with restless legs, and they say they feel they need to move their legs. You know, they felt that it feels like spiders or itchy or hot on them. And those older kids will avoid going to bed because they don't like that sensation when they lie down. The cause of restless legs, as I said, is iron deficiency anemia. It can run in families, and it's actually made worse by caffeine and antihistamines. And as if they didn't have enough to deal with, restless legs is increased in children with diabetes, sickle cell, or kidney disease. So the symptoms are this irresistible urge to move their legs, described as tingly or creepy crawly. They have a lot of discomfort in their legs, like an itching or burning. This leads to a difficulty falling asleep. And what you will see as a parent is resistance going to bed. And then that has a knock-on effect of causing daytime sleepiness during the day, which can be behaviour problems. They can appear hyperactive or irritable. And the treatment would be a consistent bedtime schedule and routine, avoid going to bed too early, increase the daytime exercise, avoid caffeine, and speak to the GP about treating the iron deficiency if their iron intake is very poor. Just to mention obstructive sleep apnea, it's a breathing problem that only occurs in sleep. And what happens is there's about brief 10 to 20-second pauses that occur frequently throughout the night. These pauses are caused by an airway obstruction. It causes a temporary drop in the oxygen, and that can cause fragmented sleep, and that leads to daytime sleepiness. So the cause of obstructive sleep apnea in children, the most common one is enlarged tonsils and adenoids. Sometimes it can be being overweight or obese, you know, but mostly it's the tonsils. But other risk factors are things like allergies, asthma, sinus infections, gastroesophageal reflux, a close family member with sleep apnea. For the children with narrow facial bones or a small jaw, they're more likely to have it. And there's an increased amount in children with cerebral palsy and Down syndrome. So the symptoms, single biggest thing that you will see in a child with obstructive sleep apnea is snoring. You know, and if a child is snoring loud and every night, that is not normal. You need to speak to your GP and they need to refer it to ENT. If you're looking at their breathing, there's pauses in the breathing, and then it sounds almost like they're choking or gasping, and that's when the breathing stops and starts again. They can have very restless sleep because they're not getting enough of that good quality deep sleep because of the obstruction. They can have frequent night wakenings. They can sweat during sleep. They can wake up with a morning headache or have difficulty wakening in the morning. And they also have daytime sleepiness, which can have a knock-on effect of being irritable or have behaviour problems. So the treatment really is referral to specialist ENT, and sometimes it's surgery. If the child is a bit overweight, then you're looking at exercise and diet. Treat the allergies or the asthma that might be making it worse. And sleep studies could be required if there's if it's not down to tonsils and adenoids, but the only place in Ireland that does that is Crumlin. And really, the kids that are referred for sleep studies in Crumlin, there's usually more complex medical stuff going on, and they're under the care of the paediatricians and referred on to Crumlin for those studies. So just to mention a wee bit about the impact of the COVID pandemic on sleep, really what the research has shown is that there's poorer sleep health and hygiene as a result of the pandemic. And that was just a loss of routine for everybody, adults and children. What happened when the schools were closed initially was there was delayed bedtimes and later wakening times. Interestingly enough, the teenagers benefited from this because, you know, their body clocks are slightly different and they function better when they get up later and go to bed later. There was increased screen time for everybody, I think, especially in the very beginning in the severe lockdown. And what happened is, even when things have resumed back to normal, the amount of screen time hasn't reduced to what it was pre-pandemic. That's what the research has shown. So there was irregular sleep-wake patterns, increased anxiety in children because they were picking up on the anxiety that the parents were having. And for a child as well, they had less social exposure. People were wearing masks, so their faces were harder to read. And I certainly would be seeing the knock-on effects of that in the wee 3 and 4-year-olds that I'm seeing now in my clinic, you know, that they haven't had the normal exposure to situations that maybe older siblings had. And there's increased stress levels generally in the community due to COVID, and the kids have picked up on that. And often if you, like I said to you before, if you see a child, if I see a child coming to the clinic and we're looking at a sleep diary, when we add up how much they're sleeping at night time, how much they're awake, but how much they're sleeping during the day, the child is actually still falling within the realms of norm that I showed you on that earlier slide, whereas it's often the parents who might be getting half the amount of sleep that the adults are getting. So just to point you in the right direction, as Nicola said at the start, you know, that you've got your My Child books that you get from the public health nurse when she does her developmental assessments. The My Child website, you know, we do the sleep content for that, and it's updated regularly. And if you have concerns around sleep, talk to your PHNs, because all the PHNs have had sleep training. And that's the end of the slideshow. And now I think we're going to take questions and answers, the questions that came in the chat.
Okay, Denise, that was brilliant. It was really informative, and I would say you've probably covered a lot of the questions, but it's great just to have a few questions here that parents have put forward. So I suppose I'll start here. There's one. My 9-month-old baby has been bottle fed, used to sleep all night, but now he is waking 4 to 5 times a night. He always slept on our knee and was then put down to the cot. He has 2 45-minute naps during the day. He sleeps sound for the first 4 to 5 hours and wakens then. Sometimes he will go back to sleep himself, but other times he wakes and is crawling around the cot like he's ready to wake for the day at 3 a.m. If we take him out and into our bed, he will sleep to 7. So I suppose that parent's just looking for some advice there.
So there's a few things there, you know. The first thing I would look at there is that, you know, the how much carbohydrate and how much the child's getting during the day. Like we said about the importance of supper, and if they have enough carbs during the day, there's no need for the nighttime feeds. If the child is in the habit of getting nighttime bottles, you wouldn't just go from full bottle feeding to not bottle feeding them. What you do is you cut down by 1 ounce each night. So say they're getting 6-ounce bottles during the night, you cut down by, you know, 6, 5, 4, 3, 2. When it gets to 2, you know it's not hunger that's wakening them, you can change it to water. But most parents are comfortable cutting down, but maybe not every night. They might do it every second or third night. So over the course of maybe 2 weeks, they are reducing and discontinuing the bottles during the night. Now, the other thing there, as we talked about, and the sleep association, if the child falls asleep on the parent's knee and gets put into the cot and sleep, and their deep sleep, when they do their first transition, open their eyes, look around, think, where did they go? And that's why they'll fall asleep easily when they get back into your bed. So what you're going to do there is what we call gradual retreat. So you put the child into the bed drowsy, you sit beside the cot because they're used to falling asleep on your knee, and you would have maybe your hand on their back. Try not to pat too much, but just have the physical contact. That can happen for a few nights. It could be up to a week. Then when they're used to going into the cot and they've got your physical touch, you take your hand out, but you continue to sit in the chair. And you do that for another few nights. And then you gradually start to creep that chair towards the door. And the idea being that when you're on the chair, you're kind of facing, that you're not looking directly at the child, so you're not making eye contact as they fall asleep. And really, you're supporting the child to fall asleep themselves, but you're supporting them to manage that. That can take, that gradual retreat process, and it's on the My Child website, can take about 3 to 4 weeks. And also the thing you can do there, if you've got a child who's over a year and has been used to the physical contact from the parent, you can bring in what we call a transitional object. So it could be a wee teddy or a blanket, and you're replacing the physical contact from you with this blanket or teddy. So so there's a few things there. You're looking at, are they getting enough carbs during the day? You're reducing and discontinuing the bottles during the night, and you're also doing the gradual retreat to get the child to fall asleep on their cot, so as that when they waken during the night, they can look around and everything's just the same.
Okay, that's great. We have another one with people or parents having difficulty leaving the room. I have difficulty leaving the room of our two girls to sleep by themselves. They get upset. They're aged 3 and 5. What do I do?
3 and 5 is a good age, to work on that you're rewarding them. I would use reward charts a good bit at this stage in the clinic. So what you can do for the child is reward them for staying in their bed. So there's a website that you can, if you Google it, free printable behavior charts. There's lovely wee charts there. I slept in my own bed. And then what you're doing is rewarding the child for, staying in their bed. Now, there's some cute children that stay in their bed but just call the parents. So once we've got them staying in their bed, we say, oh, we change the goalpost maybe the next week, and we say, staying in your bed and not calling the parent. And again, 3 to 5, your teddies, your dolls, your blankets, those comforting things that they can have are good. And then sometimes what can happen is, it depends how busy you are during the day, but 3 and 5-year-olds, it could be that if you could do the one-to-one playtime with them before the bedtime routine, they're filled up with the fact that you've seen all the things they're doing and you've heard all their stories, and they're not looking to keep you in the room because they want your attention as they're falling asleep. So I would also bring in, the one-to-one playtime with them earlier before you start the bedtime routine, just in case they're just using that one-to-one time at night time just to have your attention as well.
That's great, Denise. Thank you. We have another one here. Having a really difficult time breaking sleep associations. Been working on it for months. The parent used the pick up, put down method. Baby can be settled in the cot, 8 months old, wakes every 45 minutes throughout the night, occasionally gets a 2-hour stretch in the middle of the night. So that sounds like tough going for that parent. What advice would you have for them? Yeah.
So when you say you're working on the sleep associations, I suppose I'd be looking at what happens in the hour before bed. And it's all those cues for sleep. Is there a regular bedtime routine in the same way? Are they getting supper? Going into the cot? Make sure you're almost playing detective when you're breaking sleep associations. You're looking, is there a light on as they fall asleep that turns itself off? Obviously, if the parent's present, you're using your gradual retreat to get out of the room. And is there anything else that the child's brain is looking for during the night? So it sounds like the gradual retreat would need to be used there, where you're going to have to sit beside them, put your hand on their back, take your hands away, get out the door. But also in an 8-month-old, I'd be making sure that they're getting enough carbs, that it's definitely not hunger that's wakening them. For awakening every 45 minutes is very, very frequent. It sounds like a very strong sleep association, and you're really figuring out by a process of elimination what could it be that their brain's looking for every time they're waking up. It might just be they want the physical contact, and if it's the physical contact, then you can use the gradual retreat. Now, when you say pick up, put down, maybe, rather than keeping picking up all the time, just have your hand in the cot when they're lying down, rather than lifting them up and putting them down and lifting them up and putting them down. You might have to just tweak that a wee bit, but ultimately what you're doing is supporting them to be able to fall asleep by themselves.
Hey, Denise, thanks for that. We have one, and this is, I suppose, an issue many of us have faced over the years. How do you get a 6-year-old to go to sleep in her own bed? She wakes up every night and comes into our room. Okay,
so we've all done that. I bought a king size bed at one stage and had 3 in it before I did all this work that I do now. So what I would say to you there is, with a 6-year-old, we talked about sleep being a learned behavior. So you're really looking at your bedtime routine again, but you're also looking at, are you present in the room when they fall asleep? And then with the 6-year-olds, the reward chart works great for them, for rewarding them. But with a 6-year-old, I'd use a slightly different reward system. For a 6-year-old, I'd get like a plastic jar and have a token system. So you might have like cotton wool balls. Every time that they stay in their bed at night time, they get a token, and then before you start the reward system, you do like what they can buy with their tokens. So this might get them to the beach, that might get them to the park. A bigger reward might be going to soft play or the cinema, and they have some control on how they spend their tokens. The other thing that we sometimes use for a 6-year-old is almost like call it a pass. So you give them like a wee card, like the size of a credit card, and you tell them that they have a choice. They can get up for one thing, um, or two things. And then you say, but if you only get up for one thing, you'll get an extra token in the morning. So if they use the card, they give you back the card, they'll get one token. But if they keep the card, they'll get two tokens. So there's an incentive not to be getting up and down. And sometimes that actually works very well for the 6-year-olds. So it's finding the reward that they buy into. That's the big thing with 6-year-olds.
Great advice there, Denise. My 3.5-year-old goes to sleep really well and easily at 8 p.m. Then they wakes around midnight, and then it's on and off all night. So any advice there for that parent?
That sounds like a sleep association. So really what you're doing is playing detective. Look at the hour before bed. Is there something that happens in the hour before bed that when they come out of that period of deep sleep at 12 o'clock that their brain's looking for? So, we talked about maybe the baby massage. Sometimes it can be music, songs, lights on that turn themselves off. You really have to look at it, be a detective and figure out what their brain's looking for, something when it's waking up, coming out of the deep sleep, and it's waking in at every transition on the other cycles, because the middle of the night sleep cycles could be as short as 50 minutes to an hour and a half. So I'd really be going back and saying, right, what's their brain looking for? And it could be something very simple. Remember one wee child coming to the clinic, and it was a light up bear, and that had been in the cot since birth, and we didn't realize, mum didn't realize either, but it turned off itself, and that was the sleep association. And it took us a lot of months before we realized that, because mum hadn't told us it was there, because it had always been there, she hadn't thought about it, and that was that child's sleep association.
That's great, Denise. My little boy is 2.5 and has Down syndrome and suffers with tonsillitis also. He is on daily antibiotic for over a year, won't go to sleep without cuddles. I don't want him to scream crying, as it'll hurt his throat. Am I better to do the chair sitting and move to the door as the night goes on?
Yeah, like obviously, with the tonsillitis, the wakenings during the night could be caused by obstructive sleep apnea, because the airway is occluded from the enlarged tonsils. So really what you're doing, as you're probably on the list to be seen by ENT, is as much as you can on the advice that I've given, but you have to balance that with, you've got a child who's distressed because of a medical condition. So yeah, I think you're right. If you could sit on the chair, I would take that approach very softly. I wouldn't want to be causing the child any distress. And I mean, I couldn't listen to my own children. I'd never tell parents to let their child cry at night time. But if you can actually just support them to fall asleep, while you're on the chair and getting to the door, that's probably the easiest way. But the wakenings at nighttime could be those, the startles from the sleep apnea, and really until the ENT deal with the enlarged tonsils, that's probably going to persist.
We have another one here. My 2-year-old often wakes a couple of hours after falling asleep, screaming her head off, calling for me. Is this because of me putting her to bed by offering body contact, or is this sleep terrors?
It sounds like sleep terrors. Sleep terrors happen in the deepest part of sleep. So usually if it happens within a couple of hours of going to sleep, you're still in that deep non-REM sleep. And the reason you can tell the difference between sleep terrors and a nightmare. A sleep terror, the child looks absolutely terrified. Their eyes can be awake, very frightening for the parent to watch. But when you go to comfort them, they don't respond the way that they would during the day. And that's because they're actually still asleep. So sleep terrors have no detrimental effect on the child, but they're terrifying for the parent. Whereas in a nightmare, the child can tell you what's happening. It's really, really scary for the child, not so much for the parent, because they can tell them what's happening. So with a sleep terror, the advice would be, they can last anything between 5 minutes, half an hour. Not, you have to let it run its course, because they're asleep, you can't comfort them because they're not actually awake. So it sounds like a sleep terror, and it will run its course. Don't worry about it too much. It doesn't have any detrimental effect.
Okay. 2.5-year-old always slept by themselves and stayed asleep no problem in their cot. Since October last year, needed a parent in with them. Now we have moved to the stairs, but constantly shouting for us and waking in the night to come to our bed. So supposed to be child has gone backwards maybe there. So any advice?
Sometimes where 2.5, often that'll happen when they move from a cot to a bed. And it's almost like they've suddenly realized that they've got a bit of control, they can get out. And so what we would often do there as a short-term measure is, say the child's fallen asleep at 8 o'clock, we push bedtime out to just before that, or even keep them up till 8 o'clock. So is that they're definitely ready for bed and they go in and they should be asleep within 20 minutes. Now, if they're resisting going to bed and they're doing the calling and everything, then and they're not going to sleep to 8:30 or 8:45, you can push it out. If you push bedtime out in 15-minute slots, you don't upset the circadian rhythm. So as a sleep intervention, we sometimes make bedtime later. Once the resistance has stopped and the child goes into bed and falls asleep within 20 minutes, we creep it back 15 minutes and then maybe back another 15 minutes. So the intervention is pushing bedtime out, and then when the resistance has stopped, and we bring it back to where it was before. The most important thing for that to work is you don't change the time of the morning wakening. Morning wakening should stay consistent. If you put a child to bed later, and I've had some kids come through the clinic and we could have had them up to 10 o'clock at night. If you let them sleep on for an hour or 2 hours in the morning, all you've done is reset their clock. So what you're doing is trying to make the time in bed count. So you're keeping the morning wakening the same, but pushing the bedtime out to reduce the resistance to going to bed. And that's quite common, especially in the transition between cot and bed.
Okay, we have one here. My 3-year-old has had the bottle to get her to sleep at night. If she wakes, she looks for the bottle to go back to sleep. How do I go about weaning her off the bottle?
So it's just like I said earlier, have your supper, give the milk with the supper. Make sure if she's having, that she gets a drink. If you can, change the bottle to a cup and then reduce the volume. Just like I said, 1 ounce now in a 3-year-old, I would actually not be doing it over weeks. I'd just be cutting it down fairly quickly, because what you can do is the milk that you were given in the bottle, you can give in the supper. Generally, when I see 3-year-olds that are still getting bottles to go to sleep, they've got a very poor appetite during the day. They're filled up with milk during the night, and then their appetite for food's not so good during the day. So sometimes parents, it gets to that chicken and egg thing. Well, they're not eating during the day, and then at least if I give them the milk at night time, I know they're getting something. So what I would say is you have to kind of just go with it. You have to give the supper, cut down the milk, offer water if they need a drink during the night. They'll probably throw it back at you, but that's what you want. Especially at 3, because you're moving towards toilet training and you don't want frequent wakenings for going to the toilet during the night. So really it is just cutting down and discontinuing bottle use, moving from the bottle to the cup. Now, this time of the year, the wee kids coming to the clinic, we're telling them that the lambs need the bottles and they're being put in a bag and they're being given to the farmer. You can do whatever way you want, but really at 3, especially for their teeth, the sugars in the milk will actually rot their teeth, and we've got 4-year-olds coming through that need anesthetic to get baby teeth removed due to bottle decay. So it's a good time to move on. Really, bottle use should be discontinued from about a year. That's the advice.
Okay, a 5 a.m. wake for a child who's turned 2. They get a 90-minute nap during the day. Can we do anything better, or is this all she needs?
It depends what time she's going to sleep. A 5 a.m. wakener, when I would see a sleep diary, might be going to sleep at 7 o'clock, which means they're getting 10 hours during the night and they're getting the 90-minute nap during the day, so they're in the normal realms of sleep. So we wouldn't start there by cutting back on the nap. As I said earlier, what we would do is try and push bedtime out by 15 minutes. So say they go to sleep at 7, you'd be making it 7:15, hoping them to get to 5:15, and then pushing out to 7:30 so as to get to 5:30. And we'll just push it out 15 minutes every couple of days to try and get them to at least 6 o'clock. you know, that's a reasonable time. But you have to do it very gently. And I would leave the nap alone. I wouldn't be, you know, it would only be, say, like a 2.5-year-old, you might say, right, we'll cut the nap back by 15 minutes. But I'd start with pushing the time of going to bed and getting up before I go near the nap.
Okay, Denise, that's great. And this is the final question. 9-month-old baby, they have a good day routine, but unable to establish a nap routine due to siblings pickups. And that's a problem for a lot of families.
Yeah,
Sleeps in the car and a light sleeper, so unable to transition to bed, waking 2 to 3 times a night, sometimes ready for the day at 4 a.m.
Yeah, so, you know, we call them hidden naps. And what you're trying to do there is really, I suppose, keep them awake in the car if you can, you know, through having things to play with and stuff. And usually there's a window in the morning, like even if you are doing the pickups, you know, most kids are in like 9 till 12, that you could try and get them in for a nap a wee bit earlier. So it's making sure there's a consistent morning wakening time. And I'm sure there is in that house when they've got so many different pickups. And then it's trying to get them in before 12, before they go to pick up, to do the first pickup. And it's just working with that, really, you know, that you could try and get them a solid hour. You don't want to be driving around to keep them asleep. I've definitely come across parents that have done that, but that's a kind of dodgy road to go down, because when they wake up during the night, then they can't get themselves back over to sleep. So I'd just be trying to work with the timing of the sleep, making sure there's a consistent morning waking, and making sure there's a regular bedtime routine, you know, have all the other bits in place, and then just try and tweak the timing of the nap.
Okay, Denise, that's it. Look, I'd just really like to thank you. It was a really informative talk today, and I just hope that all the parents who are tuning in have found it helpful on their parenting journey. Thanks a million. Thank you,
Thanks,
everybody.
Nicola. Thank you.